Hi, everyone. Welcome to today's Open Mind program on stroke prevention, acute treatment, and recovery. I'm Vicki Goodman, and on behalf of UCLA's Friends of the Semel Institute for Neuroscience and Human Behavior and the Resnick Neuropsychiatric Hospital Board of Advisors, it is my honor to welcome three preeminent UCLA doctors and nurse manager who are world-renowned experts in the fields of stroke prevention, acute care, and recovery. Dr. Jeffrey Saver, Vice Chair and Professor of Neurology at UCLA and Director of the UCLA Comprehensive Stroke and Vascular Neurology Program. Dr. Stephen Kramer, Professor of Neurology at UCLA and Director of Research at the California Rehabilitation Institute. And Dr. May Noor, Assistant Professor of Neurology and Radiology at UCLA and Medical Director of the UCLA Arlene and Henry Gluck Stroke Rescue Program. We are also very fortunate to have with us today Kayla Kalani, Nurse Manager of UCLA's Mobile Stroke Unit. We are very grateful to all of today's presenters for taking the time from their busy schedules to share their knowledge and expertise with us. Just a few housekeeping notes. Today's program will run for approximately 1 hour, with the last segment reserved for your questions. If you would like to ask any of our speakers a question, we ask that you please type it into the Q&A, which is located at the bottom of your Zoom screen. And we'll do our best to get to as many questions as possible during the time allotted. But we had over 1,300 people registered for today's program, so please be patient. Today's program is being recorded and will be available soon for viewing on our YouTube channel, which you can find on our website, friendsofthesemelinstitute.org. There you will also find a library of videos from past Open Mind programs, videos from WOW, the Mental Health Summit with Oprah this past spring, a calendar of upcoming Open Mind events and special events, including our Teen Mental Health Crisis Open Mind program that will be held in person on December 5th at UCLA. Our Teen Advisory Council's inaugural Gen Z Wellness Summit on Sunday, February 25th, also in person at UCLA, and the Open Mind Film Festival for high school students that for the first time this year will be held in person and streaming on Sunday, April 21st. Please visit our website for more details, and I hope you will all join us for these outstanding programs. And now, time for us all to learn more about stroke prevention, acute treatment. Please join me in giving a warm Zoom welcome to Dr. Jeffrey Saver, Vice Chair and Professor of Neurology at UCLA and Director of the UCLA Comprehensive Stroke and Vascular Neurology Program. Thank you so much.
Thank you so much, Vicki. It's a great pleasure to be here and with my colleagues. I'm grateful to you and to Wendy and to Nancy Klopper for giving us this opportunity to talk about stroke to these wonderful group of supporters of UCLA. In the course of the 45 minutes before the Q&A, I'm going to briefly first talk about what a stroke is and how common it is. Then Dr. Noor and Kayla will talk about the acute treatment of stroke. Then Dr. Kramer will talk about recovery treatment for stroke. And then I'll close by talking about preventing a stroke, and then we'll open things up for Q&A. So let me begin by saying, what is a stroke? A stroke is injury to brain from blockage or rupture of a blood vessel. The most common type of stroke is when a blood vessel is blocked by a clot and a portion of the brain does not get oxygen or nutrients, and within minutes begins to experience injury, and within minutes to hours becomes irreversibly injured. That's an ischemic stroke, a blockage type stroke. 4 out of 5 of all strokes in the US are ischemic strokes. The other major type of stroke is rupture of a brain artery with bleeding, That's a hemorrhagic stroke. And there are two main types. There's rupture of blood into the brain and intracerebral hemorrhage, and rupture of blood into the lining around the brain, a subarachnoid hemorrhage. And 1 out of 5 strokes is that bleeding type of stroke. Subarachnoid hemorrhage most often happens from cerebral aneurysms, from tiny balloon weakened walls that some people have on their arteries that can rupture. Intracerebral hemorrhage most often happens from high blood pressure and then brittle proteins in the blood vessels. And that 1 out of 5 strokes that are that have brain hemorrhage are treated in somewhat different ways than the blockage type ischemic strokes. Today, we're going to focus on the ischemic strokes since they represent 80% of all strokes, but we'll be happy to talk about hemorrhage in the Q&A. And let me say how common stroke is and the impact it has on the US and the world. The stroke is the second leading cause of death worldwide, the 4th leading cause of death here in the US. It is a leading cause of adult disability. It is a second leading cause of dementia after Alzheimer's disease. It can cause depression and many other mental health difficulties, in addition to severe difficulties with movement, weakness, vision, and other more elemental neurologic activities. 1 in 4 people will have a stroke in their lifetime. So unfortunately, although we're making progress in preventing stroke substantially, and it's occurring on an age-adjusted basis, half as often as it did 25 years ago, it's still very common, and 1 in 4 people listening to this program will, unless we do better, have it happen. So there are about 800,000 strokes a year here in the US. And I'm happy to say the UCLA Comprehensive Stroke Center has been at the forefront of developing new therapies in each of the domains of acute treatment, recovery, and prevention. And we'll be giving you an update on that today. And we'll begin by talking about acute treatment. So we'll bring in Dr. May Noor and our nurse, Kayla Kalani. Welcome
Thanks so
to you
much,
both.
Dr. Saver. Thank you. It's a pleasure to be with everyone today. Thanks so much for joining. It's our pleasure to tell you a little bit about stroke prevention, stroke treatments, and specifically I'll focus on acute stroke treatment. I'm a stroke neurologist and interventional neuroradiologist, so I'll tell you about the medications we can give for stroke treatments and also about the other disease-modifying therapies that we can do, which are mechanical clot retrieval and other therapies. To start with, stroke is a golden hour emergency. And what does that mean? For every minute that goes by, 2 million brain cells die if we don't restore blood flow to the tissue of the brain. So stroke is a time-sensitive emergency, and that's why I'm sure many in the group are familiar with the acronym FAST or BFAST. And that acronym stands for B is balance, E is eyes, F is face, A is arm or leg, S is speech, and T is time to call 911. It's extremely important that if anyone has acute onset, meaning sudden onset, focal, meaning one side of our body or one side of our face changes, that they call 911 right away. And the reason being that we need to give the medications that dissolve clots or that reverse hemorrhage as soon as possible. And the ability of someone to recover is directly related to how fast they receive these medications. So we know now that patients come to the hospital when they call 911 by ambulance services and come to the hospital and get treated for stroke. And the main treatment for ischemic stroke, where there's a blockage of flow to a blood vessel in the brain, is the clot-busting medication. There are 2 different clot-busting medications that hospitals use right now, one called TPA or Alteplase, and one called TNK or tenecteplase. Both of these do the same thing, in which they dissolve that clot fast to restore blood flow to the tissue of the brain. Because it's time sensitive, it's important to receive that medication fast. And in most cases, that medication can be given to a patient if they're identified with stroke symptoms within 4.5 hours from their last normal time. That's why when paramedics will arrive to the home or to wherever somebody's having a stroke, they may ask, when is the last time you saw your loved one normal? That's something really crucial, important to the hospital setting so we can know which medication we can give or not give. Because if we give this blood thinning medication late, it may be not beneficial. We do this through the IV of somebody getting this blood thinning medication. In hemorrhage patients or in patients who experience bleeding into the tissue of the brain, they may be on a blood thinner. And if they're on a blood thinner, perhaps there's a reversal medication to reverse the thinning of the blood. We like to control the blood pressure so this blood doesn't continue to expand. And sometimes we also give anti-seizure medications. Now, what happens if, in spite of giving the blood thinner, that blood vessel, which is blocked, doesn't open up? So that brings us to the endovascular treatment of ischemic stroke or blockage of blood vessels in the brain. And that means doctors such as myself go in through blood vessels in the wrist or in the leg area, or sometimes even in the neck area, to go all the way up to the blood vessels of the brain and put catheters. And catheters are just pieces of tubing, and within these catheters we have wires, and we use that as a guide using x-ray guidance to go all the way where that blockage is and to mechanically remove it. Sometimes we do that by putting a stent there, and that stent is kind of like a cage of metal. It's on a wire, and so we ask that to fish out that clot. And sometimes we also do suctioning of that clot with different types of catheters or tubes. The end goal is to return blood flow before the tissue dies, and that's really critical. Which brings us to the new innovation in stroke care that's changing the pre-hospital treatment or changing the landscape of stroke care. I don't know if many in the group are familiar with Mobile Stroke Unit Initiative. These ambulances are unlike any ambulances you've seen before. They're basically primary stroke centers on wheels. In this sense, we bring the hospital to the patient. We discussed that stroke is such a time-sensitive and important treatment. And so imagine that you reduce that time of transporting to the hospital, of having the assessment on scene, of getting registered in the hospital, going to imaging, coming back from imaging, having people interpret that, then giving the appropriate medications. Because this ambulance has a CT scanner, unlike any regular ambulance, a CT scanner where we can identify what type of stroke it is to understand whether there's ischemic stroke or hemorrhage into the tissue or bleeding into the tissue. And in doing so, we bring the hospital to the patient. We have a physician covering this ambulance either in person or by telemedicine. We have a critical care or emergency medicine trained nurse. We have a CT technologist and one of the firefighter paramedics for LA County. And everything is in this one room. And we are able to efficiently and fast identify the type of stroke, treat the stroke in the field with the emergency medications, and then transport them to the hospital of most appropriate care. In fact, if you think even for the mechanical thrombectomy, we can't do that on the ambulance, but we can identify that on the ambulance using the CT scan and forewarn the hospital, and the hospital can be much faster at preparing the angiography suite and the physician team and other team members in order to remove that clot from the brain. So all in all, technology has improved a lot. And these mobile stroke units, there are about 25 to 30 in the world. We hope more and more and more establish themselves, especially within our county. Currently, we only have one mobile stroke unit alternating in different areas of the county. And to give you kind of a real world feel for how these units can help patients getting clot busting medications. So out of 100 patients treated earlier with the same medications on mobile stroke units, then later with the same medication in the emergency department, 27 will have a final less disabled outcome, including 11 of whom will be disability free, will be symptom free. So these units really expedite care, and we hope to see them, our dream is to see them available for all Los Angelinos. With that, I'll stop on my section and I'll have Kayla Kalani, our nurse manager for the mobile stroke unit, give you the perspective of what it's like to do nursing in the pre-hospital setting outside of the hospital.
Hello, all. Thank you for being here today. As Dr. Norris said, I'm the nurse manager, and I previously worked in the emergency department for 16 years. So this is something that we routinely do as a standard of care in the emergency department. But being able to bring this to the patients in the field outside of your home and just save that time has been instrumental for the patients that we treat. Our nurses are highly trained in doing neuro assessments for our patients. They are the on-site hands, eyes, and ears of the physician, communicating things via the camera and phone to help make that decision for the patient of the treatment. One of the most important things the nurses work on there is figuring out the last known well time. As Dr. Noor mentioned, the time is very, very important. We have a small window when we're able to treat the patients with the medications. And I think one of the most important things that we notice in the field is that people often are waiting to call 911. They're having these symptoms and they think, oh, maybe I'll get better, or maybe I'll just take a rest. So I just to reiterate the signs and symptoms that Dr. Noor mentioned earlier, time being very critical. If you think something's wrong, please don't hesitate to call 911 and get seen at the emergency department.
Great. Thank you so much, Kayla and May, for that overview of treating stroke as the emergency that it is in the first minutes after onset. And although these treatments can work wonders and completely save some brains in some people, and I will point out that the clot retrieval treatment that May described was invented here at UCLA. Sometimes, actually fairly frequently, patients with presenting with stroke were not able to save the entire brain, and they do experience permanent injury. And for them, the key to achieving the healthiest life possible is maximizing their recovery. And Dr. Steve Kramer will bring on as a world expert in brain neuroplasticity and recovery. And Steve, I'll turn it over to you to give an overview of brain recovery.
Thank you, Jeff. And thank you, Vicki and Wendy, for having me. My name is Steve Kramer. I'm a professor of neurology, and I'm a stroke neurologist and an internist. And I'm going to talk to you a little bit about stroke recovery. Okay, so let's set the stage here. So we've done our best. We either did or didn't get to the patient very early. We either did or didn't get the good therapies into them and the catheter and the TPA drugs to try and get rid of clots when it's appropriate. And now they're in the hospital, and they've been in the hospital for a couple of days. Well, what happens next? What's in store? And what can we do to maximize that sequence of events? This is what we think about in my lab. So in the US, the average length of stay in the initial hospital is 4.5 days. Some people longer, some people shorter. Where do they go from there? Well, they go to one of 3 places mainly. About half of people go home. They have a stroke, they get to the hospital one way or the other, and they're sent from the acute care hospital, like Ronald Reagan Medical Center, they're sent home. About a quarter are sent to an inpatient rehab facility, such as California Rehab Institute, that's a UCLA affiliate, where my lab is, and about a quarter are sent to a skilled nursing facility. They're very ill, they're not really ready for rehab yet, and that's how it shapes up. But the point I want to make is, when it comes time to leave that initial hospitalization, 4 or 5 days after the stroke on average, most people still have disability. We do good things for some of them, and we help some of those people a lot, but even still, most people still have some disability. And so, well, what happens after that? So almost everybody who's had a stroke shows some degree of spontaneous improvement, generally over the first few months, sometimes a little longer, sometimes a little shorter. If you've known somebody who had a stroke, you probably noticed this, that the way they looked by 3-4 months later was better than how they looked in the early days. This is something that we wish we could get more of, but most people still have significant disability at the end of this spontaneous recovery. Even the people who have a good recovery after stroke, if you talk to them and you sit down and you listen, they'll tell you that they can't type the same, or they can't find the words like they used to. And so even the people with a very good recovery, there's still things that aren't as they wish they were, okay? So we've got that going on. We've got the spontaneous recovery, lasts a few months, and generally incomplete. And what's more, what about the other 90% of their life? People live years after their stroke, sometimes decades, depending how young they were when they had it, right? Not always, but on average. And there can be complications as well. Some people might start to feel like they're losing their memory a little, or some people might feel like their walking is getting worse year by year. So I'm describing some sad pictures, but let's put a positive spin on it. What can we do about that? Right? This is what my lab asks, and some other recovery labs around the world. These are treatments that we study, we develop, we put in trials, treatments where the goal is, once the injury is fixed, the stroke has occurred, May and Jeff and the others in the UCLA acute team have done what they can. What can we do to further reduce disability? What can we do to get everybody looking as good as possible? And there's another side of that too, is what tests do we have to develop to match the right patient with the right therapy? If you know a bit about stroke, you know that they're very different from one person to the other. One person, it's the hand, another it's speech, another it's vision, another it's walking. So if you have a therapy that's going to help the brain rewire, help the brain recover from a stroke, you realize that it's a little bit difficult to match the right patients with the right therapies. So whenever we do studies of new therapies, we're also thinking in the same breath, what tests are we going to have to develop to figure out if somebody is likely to respond to this treatment or that treatment? So let's talk for a few minutes about some of the different treatments that are under study, and then I'll be done. There are a lot of different treatments under study. We call these recovery drugs or restorative drugs. First off, what does standard of care consist of? If somebody has a stroke and they have some insurance, which is a thing in the US, what you see is that most of the time they get a 12-pack of physical therapy, 12 sessions, or occupational therapy, or speech therapy, or some combination. A lucky 1 in 4 is deemed suitable for inpatient rehab facility, so they get some hours that last a few weeks. And after a few weeks go by, maybe if they go to their doctor, they can get another 12-pack. Most people are done with their therapy by a month or 2, sometimes 3. And therapists work so hard to help the patient get through the difficult period. But I have to tell you, and I don't think therapists would disagree, the dose of therapy most people get is relatively small. My analogy is, imagine you don't play trumpet, and I hand you a trumpet, and I ask you to play a C major scale, and you practice a couple times for a couple weeks, or you practice 1,000 times a day for months. You can imagine that in the latter case, you're going to sound better. Well, my analogy for the US healthcare system is that the amount of therapy people get is more like the former, a few bits, a few times a week for a few weeks. So one of the areas of research that my lab focuses on is using telehealth methods to give people intensive doses of therapy every day for week after week after week, right? So we call this tele-rehabilitation. Now in my lab, the focus is on arm movement. We like to say no movement, no Mozart, no Monet. Point being that we've got to get people moving their arms a lot, and we've got to have it done in the right way, supervised by a licensed occupational or physical therapist. And that's something that we do. We've done some trials in the lab. We've done some national trials, and we can start it early, we can start it late, and it seems to really help arm function, and maybe the person get overall function back too. Let's shift gears. there's a particular therapy that I consult for a company, and they developed it, and it was approved by the US FDA a year and a half ago. This was a positive phase 3 trial for a device to promote stroke recovery. Now, I don't want to appear biased, but I helped write the trial and helped run the trial, so I'm excited about it. It's approved to help with arm movement, and it's vagus nerve stimulation. They do a little surgery and put a little thing in here, and a person can get a zap on their vagus nerve. And this is an FDA-approved device for helping people with chronic stroke, months or years post-stroke, try and get some strength back in their arm. One area that I'm very interested in, we have a big grant that gets reviewed next week, is whether a certain kind of cell therapy might be able to help folks get better from stroke. This is a kind of cell that you get from bone marrow, and it's easily grown. And we want to see if giving an IV shot during rehab produces better resolution of disability than giving a placebo shot during rehab. And we're real excited about this cell type. We did one study where there was no control arm. We just gave it to 35 people with chronic stroke, and a lot of them improved over time. And so we're really hoping this trial moves forward. The last category I'll mention, and then I'll flip it back to Jeff in a minute, is that different drugs. Most of prescriptions in the US are for pills, right? Not too many are infusions. There are certainly some. And the question is, are there any drugs, are there any pills that a person could take that would get them back on their feet faster, or have them showing less disability after the stroke has resolved and things have moved forward? There's a lot of exciting candidates, and we move forward one at a time. There's been some studies that were suggestive, and we're trying to see if we can validate that. And there have been a number of negative studies. The difficulty can be from taking studies in the lab with animals and figuring out exactly what to do for humans. But we have our top people on it. So that's my summary of sort of what happens after a stroke and some of the therapies that are under study to improve that, including some of the therapies in my lab, and some of the work that we're doing right here at California Rehab Institute as part of my UCLA lab over here. And with that, Jeff, I'll turn it back to you.
Terrific. Thanks so much, Steve. And a great overview. The final topic we'll cover is how you can stay out of the hands of Dr. Noor and Dr. Kramer, because the best way to treat a stroke is to keep it from happening in the first place. So I'm going to be talking about stroke prevention. And the first thing to say is that stroke is among the most preventable of all neurologic and other diseases. More than 80% of strokes we already know how to prevent, and they're approaches that you're already familiar with. The same things that help with heart health, help with brain health, keeping blood vessels happy in the heart. Also, the same processes keep blood vessels supplying the brain happy. So we emphasize to avoid a sedentary lifestyle, to be active 20 minutes a day of large muscle activity, walking, jogging, swimming, a healthy diet, which we recommend the Mediterranean diet, which has been proven to reduce stroke, and its US equivalent, the DASH diet, which are rich in plant products and avoid red meat, to control high blood pressure. That's the leading modifiable risk factor for stroke, is having high blood pressure, which over time does increasing damage to blood vessels. So screen for it and treat it. To have your cholesterol be well managed, and we have progressively lowered the target for where we would like the LDL, the bad cholesterol, to be to prevent events. For primary prevention, optimally the bad cholesterol would be, well, optimally under 70, but at least under 100. And managing that by diet is the first step. But if diet doesn't work, we now have lots of new drugs, the standby statin drugs that are very effective, but some people have side effects. We now have several non-statin drugs that also are very helpful. If you have diabetes, then controlling that can substantially prevent stroke, and also avoiding smoking, which is a major risk factor. All of the risk factors I've mentioned are risk factors for the development of atherosclerosis, cholesterol plaques that will block arteries going to the brain and going to the heart. And those are important to manage. If people develop a very severe atherosclerotic plaque in the carotid artery, the main artery in the neck supplying the brain, there are procedures that can be done to open that artery, either carotid endarterectomy surgery to clear the plaque out, or carotid angioplasty using a columnar stent to push open the blocked artery. The other major cause of stroke is atrial fibrillation, this abnormal heart rhythm that occurs increasingly as people get older, in which the upper chamber of the heart, instead of beating regularly, has disordered electrical activity and the wall wiggles. And because of that, the blood inside the atrium stands still, and whenever blood stops moving, it tends to clot. And then eventually that clot will emerge from the heart and can go up to the brain. And actually, a third of all strokes are due to atrial fibrillation. And we can treat atrial fibrillation very well. The mainstay is with anti-clotting medicines, anticoagulant medicines. There are other procedural therapies as well. One exciting new development is the ability to screen for atrial fibrillation. Some people have atrial fibrillation present all the time, chronic atrial fibrillation, and a regular heart rhythm that you can see with any EKG that is done, or any doctor or person self-monitoring their pulse. But many people have intermittent atrial fibrillation. It comes and goes. So any one look in time, the abnormal heart rhythm might not be detected. We now have ambulatory medical monitors to monitor patients for several weeks with external monitors. We have small little toothpick under the skin monitors that can work for 1 to 3 years. And there's also the Apple Watch, which is FDA approved to detect atrial fibrillation and allows monitoring for a very extended duration. I'm part of the steering committee for the Heartline study, in which tens of thousands of people with some risk factor are being assigned to receive and use an Apple Watch, or to follow ordinary care, and with the goal that by detecting atrial fibrillation in people who don't know they have it, doctors will be able to start those patients on the clot thinning, anti-clotting medicines, and be able to keep a stroke from happening. There are a couple of other recent causes of stroke that have been identified. One to which UCLA has contributed is a patent foramen ovale, an opening in the upper chamber of the heart. 1 in 4 people are born with a patent foramina valley. And if you have it, clots that form in the veins, which probably happens to us all the time, can cross into the arteries and eventually go up to the brain. And recent work that we've done has shown that 1 in 20 strokes are related to a patent foramina valley. It's especially a cause of stroke in younger people. Stroke is a condition that, although its age increased, and the 2/3 of stroke happen in people over the age of 65, it can occur at any age. Stroke in young and mid-adulthood is more common than multiple sclerosis. In young and mid-adulthood, it can occur in childhood. It can occur in utero. Most cases of cerebral palsy are strokes that occurred in utero. And in individuals under the age of 60 with an ischemic stroke, a patent foramina valley is a fairly common cause, and we've now done trials showing that placement of a small button to close the opening in the heart can help to prevent stroke in these patients. I sometimes feel as though people are looking for a secret sauce when I talk about stroke prevention, and I end up talking about things that you already know to do: to be physically active, to eat well, to manage these common risk factors. I've talked a little bit about some of the more novel approaches that we've helped to develop recently, but the mainstay of stroke prevention is boring old stroke prevention, which you already know how to do, which many of you already are, and some of you know you should be doing better at. If you can improve your risk factors within a year or two, your stroke risk begins to substantially decline. It's never too early to start stroke prevention. We know that healthier lifestyles in childhood lead to healthier blood vessels in young adulthood, but it's also never too late to start stroke prevention. We know that even people in their 60s and 70s, if they start on a vigorous course of preventive therapy, they are able to substantially reduce their risk, and that we are at the American Stroke Association trying to have people think not just about preventing stroke as a disease state, but also promoting brain health as a wellness state. And the health of the neurovascular system of blood flow to the brain is absolutely essential to brain health, and it's the most modifiable factor to avoid dementia as well as to avoid stroke. So standing by life's simple 7 of not smoking, controlling blood pressure to under 130/80, having low cholesterol levels, being active, and the other items I've talked about. If you follow that, you can dramatically reduce your risk of stroke. So with that quick run through all of stroke medicine, I know we've covered a lot of ground. We'll bring back May and Kayla and Steve, and be happy to take your questions.
Thank you so much. Dr. Saver, Kramer, Dr. Noor, and Kayla Kalani, that was such an informative presentation. You gave us so much valuable information. Hard to keep it all in our heads, but we can rewatch this on the Friends of Samuel website beginning tomorrow. But you really, thank you very, very much. It was a really important overview for something that a lot of us wanted more information about. So thank you very, very much. And how lucky are we to be at UCLA? All of you are such pioneers in this field. And with the mobile stroke van, I just wish there were more. We're very grateful to Arlene and Henry Gluck, who established this first one and generously donated. But what happens if you live in Santa Monica and the stroke van is in Pasadena? There's actually a question that says that, so I'm not making this up. Are there going to be more emergency vehicles equipped for stroke prevention?
Great question, Vicki. I think, yeah, I think there was also a common question in the group. I apologize sometimes I speak fastly. So let's go over the acronym again for everyone who asked that question in the group. And the acronym is B, FAST. B stands for changes in balance. E stand for changes in eyes or difference in your vision, losing partial vision or losing all of vision or having double vision. F stands for face. So A stands for arm or leg. S stands for speech or language. So somebody who has slurred speech or is not making the right words or is not understanding the words. And T is time to call 911 to emphasize that this is time-sensitive emergency. And the thing to highlight about stroke is that stroke comes suddenly. Stroke doesn't come over days and weeks. Stroke is an acute onset or a sudden onset of any of these things that that we talked about. So B FAST is the acronym. And Vicki, thank you for your question. Our hope and dream is for mobile stroke units to be available not only for all Los Angelinos, but for the entire United States and the world. And how do we do that? Just because it's a new way of delivering therapy, we have to establish the evidence for which to understand, is this clinically beneficial? So a part of our mobile stroke unit journey in Los Angeles was that we were part of 7 cities in the United States to do an investigation to understand in over 1,000 patients if this would be beneficial clinically. Would patients be helped by this? And the results were astounding, not only in the study which we were part of called Best MSU, but also in a study conducted in Germany called Be Proud. And it showed that patients treated earlier on mobile stroke units will do much better than patients treated later with the same medications in the emergency department. And part of our job now is to integrate this within the fabric of EMS care in LA County. And part of it is to also understand how to get reimbursement from Medicare and private payers so we can sustain these activities, because all of the activities of mobile stroke units around the world have been supported by philanthropy and special projects funds to date. But now that we have the evidence that these are beneficial, we hope that also insurance starts to pay for them so we can have many more of them. So part of our study in LA County is that we did we call geospatial mapping, or mapping of stroke incidents all over our county system, understanding when the strokes happen, where the strokes happen, and to map out our wish, our dream of seeing 7 to 10 mobile stroke units covering the entirety of the county. This is what we hope for, and this is what we think is going to be outstanding stroke care for our Los Angelinos within LA.
That would be wonderful. And I know we would all be so grateful to have more vans available. And I hope that your wish comes true and our wish would be the same, because it's so important for and now we have this acronym that we can all keep in mind, but FAST seems to be what is so important to get that quick treatment. So thank you very much for explaining all that. We have so many questions here. We have questions about different dietary things. One about, there used to be a theory about taking a baby aspirin. Somebody's asking about fish oil. Can you, one of you, talk about, are there any preventative things besides a good, clean diet and exercise that you would recommend somebody taking on a daily basis?
Yeah, I think unfortunately there's not anything that we know is definitely helpful to take on a daily basis for everyone. People have taken fish oil, they've taken garlic, they've taken other types of remedies, and those have not been shown to be clearly beneficial. Fish oil does have a mildly anti-clotting effect, but if you are not high risk, then that could increase your risk of bleeding in the brain and not give you benefit in preventing ischemic stroke. With regard to baby aspirin, again, in people who are not at high risk, there's the possibility that it would cause bleeding in the brain, as well as bleeding elsewhere, more than it prevents ischemic stroke. And another question was, if you start having a stroke, should you take an aspirin right away? And the answer is no, for the same reason. The stroke you're having could be a bleeding type of stroke, and aspirin would make that worse, as opposed to a blockage type of stroke that aspirin would help. So unlike with heart attack, where it's almost always a blockage in the heart, and aspirin is a good thing to take right when it starts. For a stroke, we really need to get a picture of the brain and know if you have a bleeding or blockage stroke first. So best to just call 911 and get to the hospital as soon as possible.
Thank you. A lot of other questions about alcohol. Is alcohol consumption a risk factor? Stress. Trying to summarize these, there's so many. Well, for stress, I think, is one that we live in a pretty stressful world now. And
we certainly do right now. Let me talk about both alcohol and stress. Alcohol, a lot of alcohol is a risk factor, especially for bleeding stroke. And a standard physician definition of what is a lot of alcohol is one more drink a day than the physician himself or herself drinks a day. But I would say that more than two or more drinks a day for more than 2 drinks a day for a man and more than 1 drink a day for a woman it would be a dosage that would increase the risk of stroke. Likely mild alcohol intake may even protect or at least not substantially increase the risk of stroke. With regard to stress, there's a little bit of evidence that extreme stress can increase the risk of stroke. It increases the tendency to clotting and stroke occurrence, but it's really a very minor risk factor. It's different from the heart. If you're under stress, the heart beats faster, it works harder, it needs more oxygen. So the risk for a heart attack can go up somewhat substantially. But in the brain, if you're under stress, you're thinking a lot. If you're not under stress, you're thinking a lot. So the brain is much less affected by stress. So that's a little bit of good news in this stressful time.
Thank you.
One modifiable risk factor we can also talk about, maybe that hasn't brought up, is smoking. Smoking is something, when smoking cessation, that's something in our control. Some things are not in our control, like our genes, right? We have made tendency to have high cholesterol tendency, but from our practice looking at blood vessels of the brain and looking at aneurysm formation, someone who has, like Dr. Saver said, heavy alcohol use, and someone who has long history of tobacco use, not only does that weaken the blood vessels in the heart and in the brain, but we see a lot of associations with aneurysms forming. And aneurysms are kind of balloonings of the blood vessels of the brain. And if these rupture, 50% of people don't make it to the hospital because it's life-threatening. And so one modifiable risk factor that we can give the group is smoking cessation. I think that's really important.
Thank you. Thank you very much. Couple of questions here about hereditary. Can stroke be hereditary? If you have a parent that had a stroke, and I'll be disclosed here, my father died of a cerebral hemorrhage when he was 49 years old. So Is that, can heredity play a role in this?
Yeah, there are some rare conditions where there's a very strong genetic risk, but in general, there's only a mild contribution of heredity to stroke risk. If you have a parent who's had a stroke, your risk is 1.5 fold increased compared to someone who doesn't have a parent. So it is higher, but it's not that much higher than people who don't have a family background, but it is a good reason to attend to your modifiable risk factors to avoid that outcome.
Thank you. We've got a couple of questions here again. If you could go over the symptoms of a stroke once again.
Yeah, I'll say that whatever the brain does can go wrong in a stroke. So there are many symptoms. Any change in behavior or activity that occurs suddenly, we really could be a stroke. We do highlight a few that are very common, and that Dr. Noor pointed out, that the BFAST, B-E-F-A-S-T mnemonic. B is for sudden change in balance. E is for sudden change in eyes, in vision, problems moving the eyes or problems seeing. F is for sudden facial droop. A for sudden arm weakness. S for sudden speech or language difficulty. Sometimes it's easier to just remember fast, face, arm, speech. And that covers 80% of strokes will have those symptoms.
Thank you. Since we are a mental health organization primarily, I would be remiss if I didn't ask about depression after stroke. What is the rate of depression after stroke? If you could address that.
And Steve, do you want to address that and how it affects recovery?
Sure. About 1 in 3 people will have major depression by 1 year post-stroke, and a lot of it's right after the stroke. Partly it's because a bad thing has happened and they have trouble dealing with it. Partly it's because the happy, sad, balanced centers of the brain have been injured. So there's both reactive and injury-based results. I should also point out that 20 or 25% of people with a stroke have a significant anxiety disorder during the first year. It's terrifying to see something change about your body and you don't get it all back and you're worried about another one. And this includes a large number of people who get a PTSD. It's very scary. The good news is that the drugs and the talking therapy that can be helpful for people without a stroke are also helpful for people who've had a stroke. So there remain options. A lot of times people with depression or anxiety slip through the cracks because people are so worried about clots or about moving the arm again. And so it takes a careful clinician to remember to think about it and to check on it. And studies suggest that we don't diagnose depression after stroke as often as we should, and we don't treat it as aggressively as we should. That's pretty well ensconced in the literature. It's also known that somebody who has depression is going to have a harder road to recovery for so many reasons. Depression comes in many flavors, but one thing that you see in common across many people with depression is a low energy or difficulty getting started on things or apathy. And those things work against getting back function and reducing disability. And so depression is really a curse in 2 ways. One, in terms of the problems it causes, and the other in terms of how it might impede getting back movement or speech and so forth. I don't know. Jeff or May, do you have anything to add to that?
No, I think that's a great summary, Steve, and you're absolutely right. We know that physicians need to do better, but stroke provides interesting insights into the organization of the brain because strokes will affect different regions of the brain in isolation. And so the happiness and sadness centers the network for mood regulation in the brain. has been unveiled a bit by strokes that have altered it, and that is an important contributor in addition to the natural response to the deficits a stroke occurs.
Thank you. Thank you very much. We have a question here about after stroke having trouble swallowing. Is there any recovery from that or any physical therapy that can be done to help with that?
Steve?
Sure. Swallowing, so the answer is yes. Swallowing at the end of the day is muscles. And just like muscles in the arm, the muscles of swallowing can be weakened by stroke. There's one thing that helps with that spontaneous recovery is that swallowing tends to have both sides of the brain contribute. And so when a stroke, usually on one side of the brain, usually affects the other side of the body, you still got one good side, and that helps. But it's still a common problem. And a person with swallowing difficulties is probably going to see a speech therapist. Again, much of the problems with stroke can sometimes improve on their own for the first few months. And the speech therapist can help to prevent choking until that happens, but also with some exercises. There's some new electrical stimulation devices that can help with that. So my advice for somebody who has swallowing difficulty after a stroke is to see a good speech therapist and check out all the latest devices.
Thank you, Dr. Kramer. Time for one more question. And there was a question about the eyes, but I'm having trouble finding it now. But if you had a stroke that affect your vision, what would be your recommendation?
Yeah, I saw that one, Steve. It's about rehabilitation for visual deficits after a stroke.
Thank you.
Sure.
Yeah.
It's in Be Safe. Eye stuff can be a common consequence of a stroke. And one of the complexities here is that there's so many flavors of that. It can be a large blind spot. It can be double vision. It can be part of a dizziness package. And each of those different scenarios requires a different group of experts and a different group of solutions. I'll give a few generalities. One thing is any stroke doc who has a patient they're seeing in clinic, that patient needs to see an ophthalmologist once a year for the rest of their life. That's my opinion, because the eyes are now extra precious now that there's something wrong with them, okay? And as part of that, make sure that glasses are accurate. Some people have double vision because the eyes are kind of cockeyed on one side or something from the stroke. And there's a special kind of optometrist called a neurooptometrist that can put special lenses in the glasses and help the eyes see straight ahead. Finally, for people who have a blind spot, there's a controversial set of treatments where if you flash things at the edge of the blind spot, can you get some of that vision back? This is controversial. And I suppose if I had a blind spot after stroke, I would try everything. It's a hot area of research, and there may be some drugs for this in the future. But for now, that is one experimental possibility. I hope that's helpful.
Thank you. Well, unfortunately, we're out of time and there are so many questions, but I hope that we got to the majority of them. I want to thank all of you so much for this excellent presentation, really very complete and really a wonderful overview for those of us who really needed an education about stroke and treatment. And thank you for taking the time from your schedules to do this for us. Thank you to everyone in the audience who tuned in. I know it's a very trying time right now, so we really appreciate that you took the time to be with us. We have some very exciting events coming up, which I mentioned in my introduction, but visit our website, friendsofthesemoinstitute.org. Thank you all for the privilege of your time. From all of us at the Friends of Semel and the Resnick boards, please stay safe, stay well, and I hope you have a meaningful Thanksgiving holiday. And thank you, and we'll see you back here soon.
Thank you.
Bye, everyone.